So we are live.
A very warm welcome to everybody. On behalf of Bihar Ophthalmological Society and the Uveitis Society of India, I welcome you to this webinar of Decoding Common Uveitic Disorders. We have a galaxy of panelists, chairpersons, and speakers today. And without wasting time, I would like to request our President of Bihar Ophthalmological Society, Dr. Milind Kumar, to please welcome the gathering. Dr. Milind Kumar, sir.
Thank you, Satyajit. Good evening. It is a proud privilege for me as President of BOS to welcome President and Secretary of USI and convey our sense of gratitude and thanks. This is our endeavor to rope in all subspecialty societies in such joint CAB program.
Go that side.
Such meeting will be beneficial for our members to know current practice pattern and also give an opportunity to our members as a speaker in national platform. I, on behalf of Educative, thank you all for attending this webinar. Thank you.
Thank you so much, sir. I would like to request Dr. Manisha Agarwal to welcome the gathering on behalf of the Uveitis Society of India.
Thank you, Dr. Satyajit, and good evening to all. I would like to thank Bihar Ophthalmic Society, Dr. Satyajit and his entire team for giving this opportunity to all the members of Uveitis Society of India. I think platforms like this help us to spread awareness of uveitis. And having said that, I think none of the ophthalmologists' practice goes without treating uveitis. So I look forward to today's interesting session, and I'm sure it's going to be a very interactive session with a lot of interesting learnings for all of us. So thank you once again for giving us this opportunity.
Thank you, Dr. Manisha. We have a galaxy of speakers and chairpersons over here. I'd like to take this opportunity to introduce the chairperson and panelists. We are very privileged and honored to have, and in fact blessed to have, Dr. Jyotirmay Biswas sir with us. Practically half of the faculty and the speakers over here are his students. He needs no introduction. He is known nationally and internationally. However, I have to customarily complete this. He is a specialist in uveitis, and Dr. Jyotirmay Biswas has 456 articles published and has written 54 chapters in different books. He has written 3 books on uveitis. Himself he has authored and is the reviewer of 52 journals worldwide. He is the founding member of the Uveitis Society of India. Dr. Vaishali Gupta is also expected to be with us, and she is the president of the Uveitis Society of India and secretary of the International Uveitis Society. She has 350 peer-reviewed publications to her credit and is the member of the prestigious Macula Society. She is the main person behind the COTS study. Dr. Manisha Agarwal, who is present with us, she is the head of the Vitreoretinal and Clinical Research Department of Shroff Charity Eye Hospital, Delhi. She is the Joint Secretary of Vitreoretinal Society of India, and she is the Secretary of the Uveitis Society of India. We have with us Dr. Amit Khosla. He is the Senior Ophthalmologist from Gangaram Hospital at New Delhi. He runs a special rheumatology and uvea services clinic at the Gangaram Hospital itself. He has pioneered the use of biosimilars, TNF blockers in uveitis. He holds annual meetings which are very popular on uvea and rheumatology. I'd like to welcome all of you from the Uveitis Society of India to this session of BOS and Uveitis Society on uveitis. I would now like to welcome Dr. Gyan Bhaskar, who is a senior ophthalmologist, senior professor at Indira Gandhi Institute of Medical Sciences, IGIMS Patna, who will be the moderator for session 1. Dr. Gyan Bhaskar, please.
Thank you, sir, for giving me the opportunity. Myself, Dr. Gyan Bhaskar, member scientific committee of Bihar Ophthalmological Society. It is my privilege to welcome and introduce the first session speaker, Dr. Partho Pratim Majumdar, on behalf of Bihar Ophthalmological Society and Scientific Committee. Dr. Partho Pratim Majumdar completed his graduation and post-graduation from Silchar Medical College and Hospital, Assam University. He has completed his fellowship in medical and uvea from the Shankar Netralaya. Now working as senior consultant in the Department of Uvea, Intraocular Inflammation in the Shankar Netralaya, Chennai. His area of interest is scleritis, radic uveitis, medical management of uveitis and scleritis, especially in the phacoemulsification in the uveitic cataract cases. He has received so many awards, attended and presented papers in various national and international conferences, and he has published many articles in the various peer and non-peer reviewed journals and written more than 45 chapters in the various ophthalmology book. Now he is serving Indian Journal of Ophthalmology as assistant editor, UVS section, and a member scientific committee of Uveitis Society of India. With these few words, may I request Dr. Partho Pratim to start their presentation. Dr. Partho.
I hope I'm audible.
Yes.
And
Yes.
you can see my slides, right? Thank you. So first of all, I would like to extend my thanks to Dr. Satyajit Sinha and his team member, the scientific committee of Bihar Ophthalmological Society, and Dr. Manisha Agrawal, Secretary of UVS Society of India, for having me here. So I'll be talking on anterior uveitis. As the topic is vast, so in next 8 minutes, I'll try to point eight characteristic or features of anterior uveitis for the general ophthalmologist. So coming to the anterior uveitis, by the most important of any clinical entity is identification and the definition. We need to know that how it is defined. So in coming to the anterior uveitis, the anterior uveitis is defined as uveitic entity where the primary site of the inflammation is anterior chamber. Now, when we say that the primary site of the inflammation is anterior chamber, it's not that easy, because that means you have to exclude primary site of the inflammation from the other sites of the eye. So for example, the panuveitis and posterior uveitis also can have inflammation in anterior chamber, but you have to rule out inflammation from the various other structures. For example, you have to do a comprehensive eye examination and you have to rule out inflammation from the vitreous, retina choroid, and optic nerve head. So that's how we define anterior uveitis. And you have to look at the periphery of the fundus carefully, because sometimes there can be some devastating lesions like acute retinal necrosis, or here in this case, you can see the pars plana exudate, so which can present with anterior uveitis. So fundus examination, rather the comprehensive eye examination, is must in all cases of uveitis. The next important feature is the laterality of the involvement. It's very important to identify and classify the uveitis. For example, few uveitis, uveitic entities are unilateral, like viral uveitis, the HLA-B27 associated uveitis, whereas sarcoidosis and JIA, they are bilateral. Now, coming to this viral uveitis and HLA associated uveitis, if you look, the viral uveitis typically confined to a single eye, whereas HLA-B27 keeps alternating between the eyes. So first it can involve the right eye, second it can involve the left eye. Whereas in viral uveitis, it is always confined to a single eye. Now, age of the patient is very important, and in anterior uveitis, if the patient is children, then always rule out JIA. Few tips can help you to rule out the juvenile idiopathic arthritis. These are the asymptomatic white eye. There may not be any congestion. That's why it is so important to consider the diagnosis of juvenile idiopathic arthritis in of uveitis. The next is bilateral. The bilateral involvement with band keratopathy, chronic course, and if there is a pain in the joint, then you must send the patient to a rheumatologist and consider the diagnosis of juvenile idiopathic arthritis. Here is another 5-year-old child presented with gradual painless diminution of vision and diagnosed as an anterior granulomatous uveitis. You can see a lot of floppy exudates in the anterior chamber, but when we did the AC tab, it showed the diffuse anterior infiltrating retinoblastoma. So what we learned from here, that in children and in elderly patients, you need to have a high index of suspicion to rule out the malignancy. Now, corneal involvement is very important in a case of anterior uveitis. If you see corneal opposites, which is associated with diffusely distributed capes on the corneal endothelium and goes beyond the Arl's triangle, then you have to suspect viral etiology. So sometimes the CMV anterior uveitis is an important cause of viral uveitis, and it's classically characterized by this placoid or coin-shaped opacity, corneal opacity, which can occur in the center of the lesion. So next important feature is to look at the iris, because often we underdiagnose the Fuchs uveitis because we look for the heterochromia. But you have to remember that in Indian patient, we have the darker irises, so it is very difficult to pick up the heterochromia because it can be subtle or absent. So what we have to rely on? We have to rely on the blurring of the iris crypts, especially at the collarete, which gives the iris as a velvety appearance. So if you see that, you have to diagnose the Fuchs uveitis. Next important clinical characteristic is the iris atrophy. If you see this kind of iris atrophy, it can be whether it is sectoral or patchy. And if you see a dilated pupil or distorted pupil like this, you can note here the pupillary size here. So if you note this kind of pupillary dilated pupil and the patient is not on any dilatation drop, then you may suspect a viral etiology. Now, hypopyon is another red flag signs of severe inflammation, which can be associated with infection. So you have to be very cautious, and you can do a comprehensive eye examination, take meticulous history, thorough systemic evaluation, and tailored-based laboratory investigation can help you. Now, how? I'll just give three picture. A single case of hypopyon, it can have anterior uveitis, history of lower backache, recurrent attack, and you can only do HLA-B27 and sacroiliac X-ray of the sacroiliac joint. Whereas the similar picture can have a mobile hypopyon with a history of recurrent oral and genital ulcer, where you can suspect a Behçet disease. Similarly, the endogenous endophthalmitis can present with hypopyon, and a brief history and meticulous examination can help you to reach the diagnosis of endogenous endophthalmitis. Now, one must understand that the treatment goal, there is a proverb that the unlucky doctor treats the head of the disease, the lucky doctor its tail. So you have to treat from head to tail of uveitis in your clinical practice. So for example, if you see a case of anterior chamber, you need to know the course of the disease because before you start your treatment. Similarly, you have to understand whether there is any systemic manifestation in this disease before you decide on your oral steroid or immunosuppressive. I'll give one example. For example, a non-granulomatous anterior uveitis, you think of treating the patient only with topical steroid, but if the patient is, if you take a little history and if you take a history and if there is a history of recurrent attacks of inflammation and the patient is having steroid response with the topical drop, so then and on systemic examination you find that the patient is having backache or painful joint, then that is not the time only for topical steroid. You may have to start systemic immunomodulation, and you may have to send the patient to a rheumatologist. So this is how we decode the anterior uveitis. Now, coming to the topical therapy, there are two kinds of drop I keep seeing people prescribing. For example, the prednisolone acetate and the dexamethasone. If you remember the molar basis, dexamethasone is 6 times stronger than the prednisolone. So prednisolone was 4 times efficacious than your normal cortisone, and whereas dexamethasone has a 25. So it is 6 times more stronger than the prednisolone. But when you see the anterior chamber concentration, you see here the prednisolone acetate attains much more concentration than the dexamethasone. So that's why even if the dexamethasone is stronger, one should use the prednisolone acetate because it can penetrate the cornea and attains the higher anterior chamber concentration. Next, try to avoid cyclopentolate because cyclopentolate has a chemoattractive property and it can attract the neutrophil. So we don't advocate using the cyclopentolate in the treatment of uveitis. Next or last point is you have to assess the severity of the inflammation and taper topical steroid and select the cycloplegic based on the severity of the inflammation in the anterior chamber. For example, you can see here, this is a photograph, slit lamp photograph of a patient, and you can see the synechia formation in the dilated pupil. What happened actually, the patient had severe fibrinous uveitis, and the patient was started on prednisolone 4 times a day, and it was started on atropine 3 times a day. So what happened, there was a formation of synechia in the dilated pupil. So in such scenario, you have to increase the frequency of the topical steroid, and you, based on the regular examination, you have to decide on the how you taper off the cycloplegic drops. Thank you for your patience hearing.
Thank you, sir, for your nice presentation. Always diagnosis and management of the uveitis is questionable. Sir, one question from the audience.
Yes, sir.
In cases of the anterior uveitis, the systemic investigation, when and how much we can order?
That's what. It's a step-by-step approach. So you have to take a meticulous history. For example, I have given example of hypopian uveitis. So if you see a patient of hypopian uveitis, if you have to first decide where is the uveitis located. If it is anterior uveitis only, there is no inflammation in the vitreous or in the retina or choroid, then you have to take the history. You have to see whether the cornea is involved. What is the history of recurrences? If there is associated signs like backache, then you may have to think about HLA-B27. So if the patient gives you a history of oral ulceration or genital ulceration, you see some retinal vasculitis is also there, then you may have to think about Behçet's. So similarly, if the patient is having giving history of prolonged hospitalization, patient is diabetic, and there is a hypopian with significant vitreitis, then you have to refer to a vitreoretinal colleague for a biopsy, because it can be endogenous endophthalmitis. So it's basically very difficult to say or list some list of investigation which you can do in anterior uveitis. All investigation you have to decide on the basis of history and examination.
Thank you, sir. Sir, one question is important. Always we are dealing with the uveitis with a complicated cataract.
Yes.
Sir, when we can do the cataract surgery, particularly in cases of the what are the protocol we have to follow?
Yeah, ideally it is said that the 3 months of inactivity is important for that. But there are some exceptions. For example, in few uveitis, we don't wait for that. Even without any steroid cover, we use. Secondarily, if there is a uveitic cataract due to panuveitis, like Vikage syndrome. So in that scenario, you have to start the patient on high dose of steroid. And while the patient is on oral steroid, then only you should go ahead with the surgery. Because if there is a significant synechia, and while you try to release those synechia during cataract surgery and do phacoemulsification, there are chances that the patient may have severe fibrinous reaction after first post-op day. So that's why it is very important to start oral steroid in such scenario and do the cataract surgery.
Any special type of lenses you prefer for the uveitic patient?
I don't want to name. You can actually use the common conventional lenses. Means what is available in the market.
Any comments from our panelists, Dr. Manisha Agrawal or Dr. Amit Khosla, sir?
You have to decide whether it is a posterior element. Sometimes you have a posterior synechia and you think it's an anterior uveitis. You actually treating an intermediate uveitis with cataract. So it's important that you've understood that the patient has anterior uveitis, taken a good history, seen the old records, because many times the patient will just come to you who's been treated elsewhere for a cataract. So remember, a good treatment is important. So I would also advise that the patient is a steroid responder, has synechia, anterior synegonioscopy, and the chance of a rise of pressure post. All those elements should be taken into view before you plan a cataract surgery in a uveitis patient.
Okay. Thank you, sir. Dr. Manisha, you want to add something?
Yeah, so I think what is important is that you have to be very sure that the intraocular inflammation is under full control, because cataract surgery is not it's an elective surgery. So I think the most important thing for any person to plan the cataract surgery would be that you have to make sure that there has been no recurrence of inflammation even after stopping the drugs, and that's the best time when you should be planning the cataract surgery.
Okay, thank you, ma'am. One question is from our chairperson, Dr. Biswas sir. What is the role of systemic steroid in cases of anterior uveitis?
Dr. JB, unmute yourself.
Okay.
You
This
don't need to put systemic steroid in routine cases of anterior uveitis, but I do put the patients if there is a severe fibrinous reaction, and I give a very short course of steroid, like a 3 to 7 days, and get that inflammation, fibrin get cleared up, and I give. Otherwise, anterior uveitis to DKH and sympathetic ophthalmia, base sets, I give the systemic steroid, immunosuppressive agents, etc. But I don't give systemic steroid routinely. Topical steroid is so good penetration in the eye and the anterior segment that you don't need to put on the oral steroid. I want to make few on that whole anterior uveitis which has been presented. Actually, can I make some comments?
Yes, sir.
Sir, please.
Yes, sir.
Okay. So actually, I have got a presentation all the times for that students or fellows. That presentation named is the anterior uveitis. Don't think so simple. That's my message actually. And there are situations where you should not miss, like acute retinal necrosis, which can present initially with the anterior uveitis, and on the surface you will see that it is anterior uveitis. And if you don't really dilate, you will miss a very important diagnosis and very important condition which can really be destroy the eye and the vision can be lost. Another thing is that you should not miss endogenous endophthalmitis, thinking that there is a hypopian uveitis and the vitreous. If you look at that one in ultrasound, if it shows dense vitritis and is not able to see the retina, so then you must rule out endogenous endophthalmitis. And then practically I see that a lot of prescriptions comes and a lot of papers which I do, they see the anterior uveitis often is under investigated or over investigated. Non-granulomatous first episode, you don't really need to investigate, except for if it's a hypopian or fibrin, you do the HLA-B27. But granulomatous uveitis, you need to really rule out. Like all anterior uveitis is not that you should not do the first attack investigations. The granulomatous uveitis, you need to do the investigations like TB, sarcoid, particularly TB in our case. Another important thing is that I feel that Partha has told that the children can have GIA is the first possibility. Also, we need to keep in mind that children can also develop intermediate uveitis, particularly the pars planitis variant, where the patients, children, they tend to develop a spillover anterior uveitis. And some of the times they often bleed, neovascularizations in the periphery, pars plana region, and these children, they might come with a vitreous hemorrhage, and the cause might be a neovascularization due to pars planitis. And there are certain situations like GIA associated uveitis, there you need to put the patients on methotrexate or other immunosuppressive agent. Methotrexate will be a very good choice because it's a long-standing uveitis. It requires treatment, and it's the immune-mediated uveitis. You need to hit with proper drug, and that immune-mediated inflammation is to be properly addressed. So methotrexate is very safe and well tolerated in the children. I will prefer to put such patients on methotrexate for the first initial period. These are my few comments.
Thank you, sir. Sir, one comment from your side, sir. Sometimes there is a confusion about the granulomatous and non-granulomatous KP, sir. So, sir, how can we differentiate clinically uh, uh, in cases of granulomatous and non-granulomatous KP, sir?
No, granulomatous KPs can start with a non-granulomatous, like a small KPs, and then they turn into, over the period of time, they become larger mutton fat KPs, but not the reverse way. Mutton fat KPs is not seen in the non-granulomatous. Initially, a granulomatous uveitis, as I mentioned to you, it can start with the small KPs, and later on, it can become larger KPs. And then if you see an iris nodules, copy and Bushacus nodule is a sure shot granulomatous uveitis. And then you should look for TB and sarcoid in our country.
Thank you, sir. Any comments from our chairperson for this?
Can I add one more comment?
Yes, Dr. Manisha.
So I think Dr. Partho also mentioned regarding the Fuchs uveitis. So I think it is an underdiagnosed and an overtreated entity, where you often get a lot of patients who have been repeatedly treated with oral steroids and they keep coming back with recurrences. So a few things for us to differentiate from intermediate uveitis and Fuchs uveitis would be that though you see the exudates in the area of the inferior vitreous cavity, but you're not going to find any element of cystoid macular edema. And these are the patients who really don't need any kind of an oral steroid. I'm sure Dr. JB can add more, but very often I've seen these patients in our clinic and Dr. Partho also mentioned that in our Indian pigmented iris, it's very difficult to be appreciating heterochromia. So what you have to really look for is the first sign is the loss of the iris crypt. And that is what should be raising an alarm that you probably are dealing with the Fuchs uveitis. So I think this is another entity which really needs to be kept in mind. Otherwise, the patients they really are over-treated with systemic steroids.
Can I
Fuchs
add?
uveitis. Oh, okay.
Yeah, ma'am, please.
Yeah.
You know, we get confused when Fuchs has intermediate kind of vitreous opacities. Like what Manisha said, you will not have anything in the anterior chamber, even though there may be small KPs, no fluorescent cells, or even if there are little fluorescent cells, no synechiae. That is very important. There is no snow banking in Fuchs. You may have few exudates and vitreous opacities, but you will never see snow banking. And if you do OCT, you will not find cystoid macular edema. If you do fluorescein, there may be hyperfluorescence of the disc, but you will not still see cystoid macular edema. So these are the features which will differentiate Fuchs from other forms of intermediate. Vasculitis, if at all, is very mild in Fuchs, whereas intermediate can have more. No, Dr. Biswas, this is my clinical observation.
Yeah.
I'm
So
sure Sir
Fuchs
will
is,
tell
as
you.
is mentioned, very underdiagnosed and overtreated conditions.
Absolutely.
And then this is the only conditions where you could see the few vitreous cells in the anterior uveitis. Other anterior uveitis is mostly they won't see that much of vitreous cells. And then glaucoma can be one of the important combination of the Fuchs. But Fuchs glaucoma is not that very high IOP, as you see that in case of viral uveitis, where the peak is very high.
Thank you, sir. So we move to the next talk. May I request Dr. Asif to introduce Dr. Asif is the Associate Professor from BIMS, Bihar. Dr. Asif, please introduce our next speaker, Dr. Vibhuti Prasad Sinha.
Thank you, sir. Thank you, sir. Am I audible?
Yeah. Audible.
It's my proud privilege to introduce one of my mentor and teacher, Professor Dr. Vibhuti Prasad Sinha. He is currently holding the post of Honorable Secretary of Bihar Ophthalmological Society. After doing his master's, he has done his senior residency from Regional Institute of Ophthalmology, Patna, and is in charge and head of the Department of Ophthalmology at Regional Institute, Patna since 2007. He has many papers published in peer-reviewed journal and being invited as a speaker in many state and national conferences. He is at par a great academician and is artistic surgeon. Now I invite Dr. Vibhuti Prasanna Sinha sir for his presentation.
Thank you, Dr. Asif. It is wonderful to be with you. First of all, let me thank Dr. JB for being with us. On behalf of society, must thank the President, USI, Dr. Vishali Gupta and Dr. Manisha, Secretary of USI, to be with us, and all the esteemed faculty. I'll be talking on a topic that is very close to my heart, and why it is very close to my heart is that we lost 2 patients way back in 2002 when I was doing my senior residency, when Sidex inadvertently got into the eye. So we lost 2 patients. Then when I joined the public practice or private practice after pursuing my senior residency, I had an episode of 6 cases in continuation. I faced TARS, and those were the first 6 cases of my public life. So I was literally down with that. So on this note, I want to start with my presentation. So no financial interest. I'll be talking with these contents. Now, when you do cataract surgery, So cataract surgery evolved as one of the most precise, successful surgical procedure. Not only it is precise and comfortable, but also safe in terms of infection rate. The current infection rate is very low, 0.1% nearly, or even less than that. Now, shifting to the phaco and MICS has further increased the safety, and most of the risk factors, ocular or systemic, can be controlled with appropriate surgical technique, pre-operative evaluation, and proper surveillance. But it throws a lot of dilemma, more so if there is severe inflammation on day 1. So what is that? This question will hit you when it hits you like anything. So whether it is infectious or whether it is non-infectious. So when we go back to endop, eyes with fulminant frank infections are easy to diagnose and treat with defined protocol. There are defined protocol for treatment of the endophthalmitis, but sometimes it is difficult to differentiate. And that dilemma area is really crux of this talk. Non-infective inflammations are 10 times more common than infectious. You can understand that. But to turn these non-infective inflammation as non-infectious can sometimes be disastrous for you as well as for the patient. So what can be the approach? Approach 1 is you treat all patients as infective patients. The flip side is unnecessary intervention in most of the patients. So 9 out of 10 patients, you will be doing unnecessary interventions, and you can have related complications and a risk. The approach 2 is treat these indeterminate cases. When I say indeterminate, means where you're not sure whether you're treating an infectious case or a non-infectious case as non-infective or inflammatory. But this approach will require 3 very important points. Meticulous evaluation. You have to be very meticulous in your evaluation and your recordings. You have to do a very careful follow-up. You can't just let patient go away from you. And individualized approach is very essential. So we have to remember what are the factors which can lead to inflammation in the post-operative period, like hypermature cataract, phacolytic block, pseudoexfoliation, eyes with long-term myotic therapy. I'll not go into the details. Then there is intraoperative conditions like IFIS for undilated pupil, or intracameral medications use, or a complicated surgery, or a patient who has presented to you with a poor compliance. There are n number of patients, and more so in the northern area, who will come dropping their drops like anything, and rebound inflammation is going to happen in these patients. So toxic anterior segment syndrome is an acute sterile post-operative anterior segment inflammation following an anterior segment surgery. However, this can occur even with the posterior segment surgery also. So in 1992, this term came, toxic anterior segment syndrome. Before that, it was termed as a kind of inflammation. So this post-operative inflammation is sterile or non-infectious and is felt to be caused by a substance that enters the eye. So you have to have something entering the eye, but it is not always very easy to prove that something has entered the eye and which has caused. Most of the cases, it is actually very difficult to prove that what has caused this kind of inflammation. So it most commonly occurs following the cataract surgery, may occur following any anterior segment surgery like glaucoma or even corneal transplant surgery. It will occur in acute phase. In the first few hours, from 24 hours to 48 hours, it is going to present. However, late presentation can be there with IUL, manufacturing defects, as Miyake has reported, where the case is reported even after 42 days of surgery. So incidence is very low, 0.22% in large case series. But one more important thing is the most of the cases are reported and develop as a cluster outbreak. And that is very important to remember. Now, what is the hallmark? Hallmark of the histopathology is cellular necrosis, apoptosis, and extracellular damage. All intraocular structures can be affected, but most important is endothelium. So what are the clinical signs and symptoms? Blurred vision and pain is usually absent. There will be signs of ocular inflammation. Diffuse limbus to limbus inflammation is going to be there with lot of edema. Clinical hallmark is inflammation presents with a relatively immediate onset, usually within 12 to 48 hours of surgery. Then you are going to find fibrin everywhere on the corneal endothelium, into the anterior chamber, onto the iris, onto the pupil, on the lens. Everywhere fibrin is going to be present, and it depends upon the kind of inflammation it has caused. It can go up to extent that it can create hypopyon in the inferior region. So when you dilate, sometimes you get a fibrinous reaction. When you dilate this patient, you will find out that hypopyon has appeared. So dictum was, in the earlier days, we used to keep our patients sitting in our OPD or in the waiting area for a few hours or half an hour with dilator drop being put just to find out the kind of hypopyon if we are not going to miss that. So there is a characteristic breakdown of blood aqueous barrier. There is marked increase in inflammatory cells, and these cells may settle down. The pupil can be irregular, little dilated, or small if miotic has been used. Now, coming to the etiology, all kind of agent can cause stars. Anything which goes inside the eye can cause stars, whether it is BSS or is additive, antibiotics, anesthetic agents, OVDs, glove powders, enzymes, detergent, IUL polishing, cleaning, and the sterilizing compound. As per ASCRS task force, the most important cause of TARS is improper cleaning of surgical equipment. So that point has to be remembered. BSS have the potential for causing problem with the TARS, and there are reported a number of reported cases with uses of de-sterilize, or sometimes when you re-sterilize these BSS for use during the surgery, they can cause problem. And it can be because of incorrect ionic compositions, incorrect pH, osmolarity, or additive agents, or endotoxins. And endotoxin is one which is reported in one of the case series reported from USA. Now, the preservatives can also cause a lot of problem to the corneal endothelium, whether it is BAK or stabilizing agents such as bisulfite or metasulfite. So it is imperative that any medication placed into the eye during surgery are not only preservative free, but free of stabilizing agent. To be on safer side, in my principal practice, I don't use any medication whatsoever until I'm compelled to do so to use during the surgery. So intraocular anesthetics can create the TARS, intraocular antibiotics, more so when it was gentamicins, or ointment, which we usually don't use nowadays. So ophthalmic viscoelastic, viscosurgical devices are another important causes of this TARS. If you leave it behind, it is going to increase the IOP. It can cause a lot of inflammation. But the more important thing is a denatured residual OVD, which is left out in the cannulas or the tips. So it is critically important that any reusable cannula or instrument has to be thoroughly flushed at the end of the surgery. Just don't leave the OVDs there. Otherwise, it's going to dry up there, and then later on, it can cause problem in the next case. So recommendation is all cannula handpieces of fake emulsifier has to be exposed to OVD be thoroughly flushed with the sterile deionized or distilled water. Now, investigation, identify factors which can result in enhanced inflammation, proper history taking, proper anterior segment evaluation has to be done, and it has to be recorded. And these 2 points, pupil and the posterior segment, as far as I'm concerned, these are the 2 most important indicator of how you are going to treat these patients. Pupil, if it dilates, then it is going to give you a breathing space and few more hours to or on the side of endop, or it's going to give you little more time to out these fine spicules in the posterior chamber, and if they are there, naturally you have to fall on the side of endophthalmitis and treat these patients according to the protocol. So remember, again, symptoms favoring the infective origin are severe pain, nausea, vomiting. These patients, the TARS patients, are usually devoid of severe pain. The kind of inflammation you will see is not in proportional to the pain. Adnexal swellings, diffuse mild mid-stromal edema, inferior retinal exudates, or any exudate which is present in the vitreous is going to go in favor of endophthalmitis. Now, what is the treatment? The treatment is general guidelines are document positive and negative findings. Now we have to explain in clarity with the patient attendant that, look, we have got little more inflammation than what we were expecting. Either this can be inflammatory or it can be infective. So we have to wait and we have to keep a very close watch when we treat you, and we will take decisions accordingly. So these patients require close follow-ups, maybe even 6-hourly follow-up. So if you have an indoor facility, admit these patients. If you don't have, then at least you have to make sure that these patients turn up on the next day again. So topical antibiotic as per the antibiotic protocols, and the anti-glaucoma medication has to be added since the patient IOP is going to rise. So immediately start with the topical steroid, 1% prednisolone, as discussed by one of my earlier colleagues, is going to work for you. Dilate the myo's pupil with the TP, since it is going to give you information what way you are going to treat these patients. If the pupil dilates, it is going to give you information, lot of information. So one thing is going to happen whether the when pupil is not dilating, posterior segment is not visualized. Treat these patients as clear-cut case of endophthalmitis. You are not going to lose these patients if you treat these as patients as endophthalmitis. But if the pupil dilates and fibrin starts breaking, evaluate the posterior segment. So when you dilate these pupil and you see the posterior segment haze can be present. Then if the haze is present, treat this patient as a case of endop. If the posterior segment haze is not present and the vitreous is clear, the retina we can see very clearly, call the patient next morning. So you have got another 24 hours or 12 hours to follow up these patients regarding their sign and symptoms. On each follow-up, we have to clearly evaluate in terms of all the signs and symptoms. And if any worsening is present, it should go in favor of infectivity rather than in favor of TARS. So we have to be sure, and if it goes in favor of infective, then there is defined set protocol according to which we have to treat these patients. What are the outcomes? Most of these patients recovered completely with few residual signs of inflammation or pupillary irregularity. But there can be 3 devastating complications. If you leave these patients long-term as with the lot of inflammation, the corneal decompensation can occur because it is damaging your corneal endothelium. Secondary glaucoma, and which is intractable kind of glaucoma, can occur, or CME can develop. But most of these patients, if you treat them well and according to the protocol, these patients are going to recover nicely with a good kind of vision. In case of cluster break, what I was talking was about a single case or 2 cases, but when it occurs as a cluster outbreak. Now, when cluster outbreak occurs, usually we should treat these patients as a case of endop, and all protocols should be used. Howsoever, it has to be proven later on with the aqueous or the vitreous tab that this patient was of a TARS. Reasons to be searched out, including ruling out of infective origin. There is a guidelines present in the given.
Time is over.
Yeah, we must be aware of various guidelines for cleaning. So what is the take-home message? Surgical centers and hospitals should have a proper guideline placed regarding the cleaning and sterilization of instrument. Proper follow-up of post-operative patient is must. step-ladder approach can save vision as well as patient from unnecessary procedure. Pupil and the posterior segment evaluation is of most important parameter, going to be most important parameter. A meticulous follow-up and recording has to be done, and proper dissection of any increase in level of inflammation will save the surgeon from the future catastrophe. At the end, let me thank you on behalf of Regional Institute of Ophthalmology, and also let me thank Dr. Satyajit Sinha, who is today starting his career in Bihar Ophthalmic Society as Chairman Scientific Committee. I'm sure he is going to do a wonderful job, and he'll take Bihar to a newer height. Thank you, Dr. Satyajit, and everyone for patient here.
Thank you, sir, for your nice and nice presentation, sir. One question is from our chairperson, Dr. Biswas, sir. What is the most common cause of TAS in your clinical practice, and how to prevent it, sir? Biswas, sir.
Dr. JB, unmute yourself, please.
So I don't really see that task, but I've seen a lot of IOL-induced uveitis used to come earlier, and it has reduced to a great extent. Now with that type of the IOL which you get over there, and the IOL-induced uveitis is not that much very common. But what I feel that TAS is, of course, is a definite entity, but we should be always in close guard that you should not miss an endophthalmitis, which can also present as a fibrin reactions with hypopian. And at the earliest opportunity, we should take sample from the eye, like an anterior chamber tap. There's no harm in taking a small procedure and submit for microbiological study like smear culture and or even molecular biologic study like PCR.
Thank you, sir.
Gyan. Can I just make two small points here?
Yeah.
Yeah, thank you so much, sir. A great discussion on TAS. Just wanted to reiterate 2 points which you yourself had mentioned. A lot of times these TAS episodes occur in clusters. And that is why it becomes very important for all of us surgeons to ensure that we properly document the batch numbers of whatever we have used in our ophthalmic surgeries. That helps in tracing back the point or the nidus of infection, and will often be very valuable not only for TAS but also in case of cluster endophthalmitis. So important to always document the batch numbers of whatever you have used, be it viscoelastic, be it trypan blue, be it your fluids. So it's important to do that, number one. Number two, a lot of times clinically when you see those patients of TAS, there will be intense inflammation, but if the pupil is dilating, you will be able to appreciate sometimes a good glow behind that inflammation, which is a clue to the fact that it is predominantly involvement of the anterior segment. The posterior segment still may be spared, but it's important to keep on monitoring these patients closely, start them on intense topical steroids and see the response in a few hours. So if your patient is not worsening, that, or if the patient is improving, then those are again points which go in favor of this being an inflammation rather than an infection.
Sir, can we use the RL, visco material or BSS or instrument separately in every cases to prevent the TAS infection? Is it possible?
So as per the guidelines, the single-use thing has not to be used twice. This is the guideline.
Gyan.
This is the guideline. Single-use instrument has not to be used twice. Howsoever, but we still are developing country. We train to use our instrument twice, thrice, and as many times as possible. But the most important thing, the point which was raised by Dr. Mudir, that yes, all the records need to be straightforward, so that if something happens, one, we have to make sure that we don't use we use a proper protocol for cleaning, from cleaning of equipment to use of the equipment. Number one. Number two, we have to be specific about recording which batch, which drug has been used in particular cases, and the records has to be very straightforward, so that if the level of inflammation is little more, then we can actually look into what has happened, which bottle has been used during those surgeries. So everything has to be recorded during the surgery to find out actually the cause of TAS. But most of the time, it is really difficult to find out the actual cause. Only thing you can find out is whether it is TAS or whether it is endophthalmitis. So that has to be done.
Sir, how much early and late can TAS present after cataract surgery?
So typically it is within 48 hours, the early stages, but even it can occur in the late stages. A few of the records are there, and more so with the IOLs, with the use of IOLs, since the polishing agent uses aluminium, something like aluminium material into that, and that can cause a little bit of inflammation, or even the endotoxin which are left over and which are more than the desired concentration or approved concentration, then it can cause little late kind of inflammation also. But the most important thing is we have to treat these patients early. We have to treat these patients with caution that we don't miss endophthalmitis, and we have to treat these patients rigorously, since any inflammation, any prolonged inflammation is going to damage some or other structures of the eye, whether it is endothelium, whether it is pupil, whether it is trabecular meshwork, or whether it is macula. So we have to treat these patients very patiently and very aggressively.
Thank you, sir.
Yes,
Just
yeah,
wanted to-
I just want to make a comment.
Yes, sir.
It was really a nice talk. I just want to say, okay, my first test with the TAS goes back to late 90s and early 2000, when cluster of TAS appear in our town. So what thing I came to know from the personal communications with the operating surgeon and from myself, one agent was common in all places. So that is one thing. And second, after going to the literature, what Vibhuti has told, powder gloves, but non-powder gloves or powder-free gloves are also implicated in TAS etiology, because in the manufacturing of powder-free gloves, we use a chemical in the mold which can be a causative factor for TAS. What I do in my OT practice, I flush all the cannula and wash my powder-free gloves with BSS or the normal saline. Okay. And then I use it, first thing. And second thing, before introducing any cannula, this was a age-old practice you can see in my ICS day. We dip all the instrument in the hot water, then introduce in the eye. So I dip it in the normal saline and then introduce in the eye. So these are the things can reduce the incidence of TAS. Thank you.
Thank you, sir. We are running short of time, sir. So we move to the another talk. May I request our another member scientific committee, Dr. Dinesh Kumar Bhagat, to introduce our next presenter, Dr. Cecil Narayan. Dr. Dinesh.
Doctor, please push upward arrow. Hello. Yeah, just press up arrow. जो नीचे arrow ऊपर का arrow दबा दीजिए. Where? Which arrow? Left का arrow या ऊपर का arrow, sir, कुछ भी काम. Yes, you can. Yes. Good evening, everybody. Am I audible?
Yes.
Good evening, everybody. First of all, I want to thank Dr. Satyajit Sinha and Madam Agarwal to giving me the opportunity. And now we have another prominent speaker, Dr. Cecil Narayan sir, who is presently consultant in Saraf Eye Center, New Delhi. He has done MBBS from UCMS in 1990, awarded DMA Best Medical Graduate Gold Medal, and MS from GNEC New Delhi in 1994. He has research fellowship Uveitis in 1994 and Bihar Fellow Shankar Netralaya, Chennai 1994-96. He has done FRCS ED, FRCO, in 1995-96. Is a registrar, Yorkshire Uveitis Register. He has done Vitreoretina Fellow, Hull, England. He has a special interest in infectious uveitis and ocular imaging, especially pediatric UWF imaging. He is conducting DNV training program at Saraf Eye Hospital. Thank you very much. Over to Sisir Narayan, sir.
Thank you for your kind introduction. Am I audible?
Yes, thank you, sir.
And can I share my screen? Is it visible, sir? Is my screen visible?
Yes. Yes.
Okay.
Yes, Shishir.
Thank you. So I'll talk on diagnosis and management challenges in ocular toxoplasmosis. And everybody who's present here is definitely seen lots of toxoplasmosis patients. So I will just share my own particular experience with toxoplasmosis. So the clinical presentation, I'd like to draw your attention to the USI newsletter. A lot of labor has been done, and the January 2020 newsletter was dedicated to toxoplasmosis. So, the interested audience can actually check and go to the USI website and look at the toxoplasmosis article. I had the good fortune of being a co-author to the multimodal imaging article that was recently published in Ocular Immunology and Inflammation on toxoplasmosis, and I'll draw your attention to some of those features and try to help that have helped me in the diagnosis. So this is one patient. You can see here a pigmented scar, and there is a heel lesion here and an active lesion here. And this is an ultra-wide field photograph of the same patient. Now, when we do the angiography, you see an area of block fluorescence where there was active inflammation, and there is a transmission defect coming in the area where there was scarring. And slowly, there is a leakage from without inwards, giving a ring of fire appearance. The reason I'm talking about this feature is because sometimes in dilemma cases, these patterns can help you in making a diagnosis, and I'll share that with you. And an ICG, of course, shows you the decreased perfusion that is there because of the severe retinochoroiditis. Now, the same patient I showed you, on ultra-wide field angiography, you actually pick up another peripheral lesion here, and you see a vasculitis that is occurring, and Chiarelli's vasculitis is known with toxoplasmosis, and you can have a leakage from the disc. So not only is there a posterior pole lesion which is active, there is a small peripheral lesion which is active. And sometimes you will only have a peripheral lesion without a posterior pole lesion. So atypical ARN-like picture can sometimes be seen with toxoplasmosis, and it is the most common cause. 62% of the cases of ARN simulating lesions were with toxoplasmic retinochoroiditis. So I've got a patient of an ARN here on one side, and you can see here a confluent area of retinal necrosis. There's an area of retinitis which is active. On this side is a peripheral lesion where it is pigmented here, and there is an area of retinitis here. Now, when I do the angiography and we look at the picture that I had shown you, you start seeing an early transmission defect here while there is a block fluorescence here. And in the late frame, you see that there is a staining here and there is still a leakage that is coming here. Leakage from the disc and a bit of staining from this vessel wall. And that helps me to make a diagnosis that this is peripheral toxoplasmosis and this is not acute retinal necrosis. And I'm sure Mudit will be showing a lot more cases. This case I shared with Dr. JB. So there is a peripheral lesion here. You can see on the infrared very nicely the lesion because they are superficial lesions. And once you give the appropriate treatment, it heals very well. And you do the autofluorescence of the same patient, there is hyperautofluorescence in the active phase, and once it's completely healed, it's gone. So multimodal imaging actually helps you sometimes in making the diagnosis and differentiating subtle lesions. Now, there are certain sequelae of severe toxoplasmic inflammation which I want to draw your attention. So you see here very severe inflammation, and you call this something like the headlight in the fog. And when the vitritis clears up, you have this lesion coming up, which is pigmented and a scarring here. But this very severe vitritis actually induces an inflammatory PVD. And you can see here one eye, which is absolutely fine. And this eye, which had a healed toxoplasmic retinochoroiditis, has a vice ring coming on. And here, another case, which I have serially documented. This is an active inflammation at the end of a scar. And later on, once it heals, you can see the PVD. If you cannot appreciate it here, in the zoom, you can see very clearly the vice ring. So the severe retinochoroiditis actually induces an inflammatory PVD. So now if I have a lesion here, which is peripheral, I think it is toxoplasmosis. I do a peripheral OCT and I get a very shallow PVD, and I can see cells here. So I know I'm dealing with an inflammatory lesion, and my differential diagnosis will include toxoplasmosis. Another case here, there's an acute inflammation in the mid-periphery, and this is the healed lesion, and serial OCT shows the area where there is retinochoroiditis, there is an adhesion, but a shallow PVD with cells can be made out, and that will help me to differentiate that this is an inflammatory lesion. So when I reviewed literature and you look at OCT in ocular toxoplasmosis, you know, there was one article which dedicates itself to PVD, and there are other reports, and this is one of them. You can see the angiography has been shown here. They have shown the OCT, but this feature has not been mentioned. So some of the faculty here and senior people, they can review their patients of ocular toxoplasmosis and see if they can see this. So sometimes when you have focal retinochoroiditis here, the posterior pole doesn't look that bad, but when you look at the periphery, you start seeing a very thick pars plana membrane. So you have got a center periphery connect, and that can be there in toxoplasmosis as well. And this patient ultimately required a vitrectomy for this very severe inflammatory membrane. So now again, those features of angiography that I showed, this is a healed lesion, and there is a CNVM that has come through. So the angiogram is showing two things: the toxoplasmic picture or the choroiditis picture and the CNVM picture, which is superimposed. So there is an area of staining that is coming in, and there is an area of leakage with block fluorescence from the heme. So you have to keep your vigil for the various changes that can occur. So there is an active disease and there is a sequelae, and both are concomitantly present in the patient. So you can have severe neovascularization after severe inflammation. You can have actually vessels can kink, and actually it can cause a vascular blockade. And you can, this is a pigmented lesion here. There's an active area of inflammation, and you can see the vasculitis blocked and BRVO occurring. BRVO occurring. Am I audible? So you have scar formation, vascular occlusion, NVE, CNVM formation, and an inflammatory PVD that can occur with RD. Dr. JV is very fond of this, that IgG does not confirm toxoplasmosis, but negative is significant in ruling out the disease, and positive IgM actually suggests an active inflammation or a recently acquired infection. The treatment, I'll just summarize. There's classically the triple therapy was given, but we have moved on to oral clindamycin, 300 milligrams 3 or 4 times daily. And we can also give the Bactrim, which is the combination of trimethoprim and sulfamethoxazole. And if you are having a recurrent disease, then bi-weekly treatment or twice a week treatment of Bactrim has been shown to be effective. Another thing that's really helpful is clindamycin, and the dose is 1 to 1.5 milligram per 0.1 ml. So you have got two injections are available. I use the 300 milligram per 2 ml. That means 1 ml contains 150 milligram. I dilute it in 1 in 10 ml and use a 0.1. So that is straightforward for me to give the intravitreal dose. So benefits are you can give in pregnancy where there is a reactivation. So it's an IgG positive disease, IgM negative disease, you can give it. If there is an ARN-like condition and systemic treatment is not good enough, you can add on. You can give clindamycin along with it. Intolerance to systemic treatment or non-compliance. So these will help So this is one patient of pregnancy, which Dr. Ale has very kindly shared with me, and you can see that intravitreal clindamycin has helped. But you have to be sure that this is not a recent infection and it's an IgM negative patient. Otherwise, you would have to advise medical termination of pregnancy. So this is a patient with an ARN-like picture, and intravitreal clindamycin has augmented the treatment. Just a word of caution, we now are giving a lot of intravitreal steroids. So we give dexamethasone along with clindamycin. We should not give triamcinolone. The reason is that the half-life of clindamycin is 4 days, while that of triamcinolone is 1 month, and that will tilt the balance towards steroid. We are talking about infection and non-infectious uveitis, so that will be a disaster, and you can actually get toxoplasmic endophthalmitis, as is reported in 2 cases after IVTA in the Indian Journal of Ophthalmology. If your patient is not improving and is worsening on steroids, stop. Even if the toxoplasma report has been negative earlier, please repeat it. A third or a fourth time it can come positive. And I like to summarize my talk with just one very interesting case, who's an HLA-B27 positive patient, and his fundus has a congenital toxoplasma and a congenital toxocara, and he wanted clearance for anti-TNF, and I said, you know, you can reactivate them. So he has finally taken Enbrel, while he has not taken the adalimumab or the stronger ones, and he has done well. So with that, I think I'll summarize my talk and share some of the findings which I find unique in my experience to toxoplasmosis, and I'd love to have the opinion and comments from senior faculty members here. Thank you very much for your patient hearing.
Thank you, sir, for a nice presentation. One question from Vaishali Gupta, ma'am. What are the current gold standard investigation for the toxoplasmosis mimickers?
Can you repeat the question? What are the gold standards?
Investigation for the toxoplasmosis mimickers.
I think the most important thing is still the clinical clue. When you look at toxoplasmosis, it is retinitis. There is headlight and fog. You may see a scar next to it, and fissure is beautifully shown. You may see scar in the periphery. You may see chryalisis, arteritis. So most important thing is that when it is retinitis, predominantly retinitis, only thing that can resemble toxoplasmosis, sometimes viral, because virus can produce retinitis. And the third thing which can resemble is retinitis due to Behçet's disease. Rest, everything else causes choroiditis, not retinitis. So to my mind, how would you differentiate it from viral? Before you do something more, just do the OCT and look at one thing. Toxo would have the choroidal involvement most of the times. In OCT, the viral retinitis would not have. That is mostly retinitis. When you look at the toxo OCT, you may see PVD, what Shishir was showing, and we have already published this, that on the PVD, you will see these, we call them precipitates on the surface of the PVD, which might show a mirror-like image on the retina. That is something very categoric for toxoplasmosis. The retinitis that you see has the choroidal involvement. So I will basically rely on my clinical judgment. If I'm suspecting Behçet's, the fluorescein shows capillaritis and fern-like appearance. That is very typical of Behçet's. So these are the 3 common conditions which produce retinitis. So what my teaching is, just focus whether it is retinitis or choroiditis. If you are sure there is retinitis, your differential diagnosis automatically gets truncated to very few diseases.
Thank you, ma'am. Any comments from Biswas, sir?
I just wanted to tell you that multifocal retinochoroiditis or multifocal retinitis, as well as diffuse retinitis, if you see that, particularly you should think about HIV. And such cases where suspecting toxoplasma, you should also do an ELISA for HIV. That's very important. And as mentioned by Dr. Bishali, I also used to do a EDI OCT to see the level of the retinal lesions, retinitis or retinochoroiditis. If it is not only retinitis alone, is very unlikely to be a toxoplasma. It should be retinochoroiditis.
And may I also add one more comment?
Sure.
Negative toxoplasma is often very useful, and you need to revise the diagnosis, relook at the diagnosis when is the negative. And particularly if such situations arises as dilemma or there, particularly when it is the HIV positive case, it might be negative, you should do a PCR for toxoplasma, though the sensitivity is not that high. If you have facility to do the toxoplasma PCR. Manisha.
So I just wanted to add one more thing, that when you have a toxo lesion very close in the macular area, we really need to be very careful that it very often develops a CNVM. I have seen people who have missed out on a CNVM thinking that it is just the extension of the toxoplasma lesion, and it has caused a drastic drop of vision. So as Dr. Shishir also showed beautifully in one of the snaps, so we have to be very careful and look for a CNVM. And the clue would be when you have these hemorrhages on your clinical examination on a slit lamp biomicroscopy. So that is something which should raise an alarm that you probably have an underlying CNVM, which is growing out of the toxoplasma scar. And one needs to then shift over to anti-VEGF treatments.
There is a recent article on IgM positive toxoplasma. They tend to involve the posterior pole much more. And this is from Moorfields. This just has come out.
I just want to say, you see, I always, for a long time, believed that toxoplasmosis was usually a congenital disease with reactivation. But when the Kedarnath tragedy occurred, there were a lot of people who got stranded on the side of Ganga, and they drank that water. And I saw 3 or 4 patients of acquired toxoplasmosis from that water. So since then, I keep the diagnosis of acquired toxoplasmosis as well as a congenital with a reactivation. Dr. Vishali, what is your experience with just an acquired adult onset toxoplasmosis, not in immunocompetent people?
Ma'am, please unmute yourself. Ma'am, please unmute yourself.
And Dr. JB, of course, both.
Ma'am, please unmute yourself.
Vishali, we can't hear you.
Sorry. A report came from Brazil many years ago, in which they found that the vaccination for toxo could reduce the incidence of ocular symptoms. Mothers were receiving actually for toxo, anti-toxo. So I think we have been seeing a lot of acquired variety, and your observation from Kedarnath tragedies, wonderful. But we do see many a times just no congenital scar. And one thing I wanted to point out, what Manisha was said was, many a times CNV is mistaken for recurrence, because CNV may come, few months later. So patient comes symptomatic and then they are started on antibiotics or intravitreal clindamycin again. So it's very important to rule out a CNVM if what seems is not very classical of retinochoroiditis.
Thank you, ma'am.
There is a report from Coimbatore. There is a report from Coimbatore. There is from water tank. There is a contamination, and they reported in archives of ophthalmology about 150 cases of toxoplasma from the contaminated water. I don't get much history of pets in the acquired toxoplasmosis cases. So you need to, even if there is no pets, you should not really think that it is not toxoplasma. Acquired toxoplasmosis is quite common, and contaminated water is one of the source. Contaminated water or vegetables, contaminated vegetables. uncooked.
Yeah, because the Western literature only talks about uncooked meat because they don't have the water problem. But in India, we have the infected water. So the epidemiology and demography is different of toxoplasmosis in the Western in India. That's what I wanted to say.
Dr. Cecil, one question is already you have mentioned, but when we decide we go for the intravitreal or systemic management in cases of toxoplasmosis, and how long we can give the antibiotic?
Yeah, you see, generally, if you are sure, like Dr. Vishali said, it is a very clinical diagnosis. Sometimes even if the test is not conclusive of toxoplasmosis, but clinically you feel that I will go for oral treatment. Some people who are not able to tolerate that, or if the disease is very severe, or you want a very quick control when the lesion is very close to the macula, then you would want to give an intravitreal. Dr. Payman actually did the first pilot study of intravitreal injection of clindamycin, and he showed that 2.6 to 3 injections were enough to control the disease, and there was an equal efficacy. So, you know, if there is a special situation, you definitely want to give intravitreal clindamycin, and if there is a non-tolerance or drug sensitivity, clindamycin I think we give for 7 to 10 days, because after that the chances of pseudomonas enterocolitis becomes more, and pseudomembranous enterocolitis becomes more, and I then shift my patients from clindamycin to Bactrim. Dr. JV or Dr. Vishali, what do you do?
I don't see any pseudomembranous colitis so far. I have seen only 1 or 2 cases. I give clindamycin for 8 weeks, and I combine with the Bactrim DS also, because this is such a sight-threatening disease. I give the double treatment. Even I combine sometimes with the clindamycin and azithromycin.
I think one important thing to remember is whatever treatment you give, local or systemic, don't start steroids
Immediately
before you give antitoxo treatment if you are suspecting toxoplasmosis, because that creates a lot of problem. So every toxoplasma case doesn't need emergency treatment. So for all the comprehensive ophthalmologists, if you are not very sure, and if you are suspecting toxoplasmosis, and if you think the report is awaited and in the meantime you would start steroids, don't do that, because steroids really cause damage. So it's better
Thank you, ma'am.
Yeah.
Dr. Amit, you can add something.
All the points have been well highlighted. The only thing is when you suspect, you see a small scar in the periphery, you should suspect also. The main thing is suspecting it.
Your voice is not clear, sir.
What I'm saying is one has to mentally suspect and toxoplasmosis. Can you hear me?
Yeah. Not clear, sir.
Yeah. So suspecting toxo and doing an OCT of the area will give you a clue to the diagnosis. All combination from Cepra to Clinda, the only thing is that the patient is what should be presented in pregnancy, the risk to the fetus will be there. So some people advise giving systemic therapy in pregnant patients with toxoplasmosis.
Okay, thank you. I would like to thank Dr. Gyan Bhaskar for moderating session 1, and I'd like to thank all the speakers. I would now like to request, and once again, Vishali ma'am was not there, so a very warm welcome from Bihar Ophthalmological Society, ma'am. Initially, you were not there, so we would like to warmly welcome you. I would now like to request our Secretary of Uveitis Society of India, Dr. Manisha Agarwal, to introduce the chairperson and the panelists for session 2, please.
Thank you, Dr. Satyajit. And I have the pleasure of introducing the chairpersons for the session 2. So we have Dr. Milind, who is the current president of Bihar Ophthalmic Society and a senior ophthalmologist from Purnia. We have Dr. Arvind Jaiswal, who's the former president of Bihar Ophthalmic Society and former president of Eastern India Zonal Ophthalmic Society. We also have two panelists, Dr. Vishwaratan, senior member of the Bihar Ophthalmic Society, who has served Bihar State Health Services for last 27 years. And he's also currently working as the associate professor in Venkateshwar University of Medical Sciences at Gajraula, UP, and also a full-time associate professor in Style Joseph University, Tanzania. We also have Dr. Sanjay Sharma, a senior and active member of Bihar Ophthalmic Society, a well-known ophthalmologist from Bhagalpur in Bihar. And now I would just request Dr. Gyan Bhaskar to take over, please.
The session 2 moderation will be done by Dr. Asif Shahnawaz. So I'd like to request Dr. Asif Shahnawaz to please take over session 2.
Thank you, sir. Thank you, ma'am. Now,
he's got disconnected.
He got disconnected. So it will take time for him to reconnect. I'd like to request Dr. Ranjan Rai to please introduce the first speaker, Dr. Abhishek Gupta.
Good evening, all. Dr. Abhishek Gupta is a very hard-working, innovative, and very dynamic surgeon of Bihar. He has done his MS from the Army Institute of Medical Science at Delhi, and currently he is working in AIMS, Patna. He is also ex-VR fellow from the Madurai, Arvinda Madurai. Welcome, Abhishek.
Good evening, sir.
Hello.
Good evening, sir.
Good evening.
I will share my screen.
Asif, you got disconnected, so I just carried on. You can do the next one.
Good evening, everyone. So I feel extremely humbled to present in front of the mentors to whom I have grown up listening, the Uvia forum. So my topic is retinal vasculitis. So retinal vasculitis implies inflammation of the retinal vessels, and it can either be because of a local ocular condition or secondary to some systemic condition. It is characterized by perivascular sheathing, vascular leakage, and occlusion. It is a sight-threatening disease, and it can happen secondary to an autoimmune, inflammatory, or neoplastic disorders. Coming to epidemiology, it is generally seen in younger population, generally less than 40 years of age, with male preponderance. It is generally bilateral disease, and the causes are multifactorial. So if you look at the causes, there are many plethora of causes, but we should keep in mind some of the important most causes. Coming to infectious, among the bacterial, TB and syphilis should be the first in mind. Among viral, the herpes zoster, varicella zoster, cytomegalovirus, they are the leading causes of vasculitis along with retinitis. Primary ocular disorders can also cause vasculitis, and among the most common is the Eales disease, birdshot chorioretinopathy, and pars planitis. Retinal vasculitis can also be because of a secondary systemic disorders, secondary to Behçet, sarcoidosis, SLE, and rheumatoid arthritis to be the most common. And sometimes it can be because of secondary to a life-threatening disease such as leukemia and lymphoma. So by seeing all the list of differential, it is really important to know how we should work upon a case of vasculitis. So the workup begins with adequate history taking. Patient should be inquired about the nature of ocular symptoms, and more important, the nature of systemic symptoms, whether he had any fever, cough, rash, weight loss in the recent past, and subtle and almost attention should be paid to the signs such as whether the veins are involved, or whether the arteries are involved, or whether there was any intraretinal infiltrate, cotton wool spot, retinal necrosis, or frosted branch meningitis. So I will present some cases where these signs help in narrowing down the list of differential diagnosis. So if you see this case, so if you see one vessel getting involved over here, if we follow it up to the disc, then it is seen that the veins are involved. So generally, veins are often involved in retinal vasculitis. So this is termed as phlebitis. And whenever we see a case of phlebitis, then the DD of tuberculosis, sarcoidosis, Behçet, and multiple sclerosis should be among the top of the list. If you see this case, this is also here the vessels, the veins are involved, and the involvement is something segmental in nature. So these are actually skip lesions. And whenever veins are involved, we should think of sarcoidosis, especially when the involvement is segmental or skip lesions are present. So this is another case. If you see the FFA picture, there is focal inflammation of this vessel. If you trace it along to the disc, then you see this is an artery which is getting involved, not the vein. So this is a case of arteriolitis. So whenever we see a case of arteriolitis, the causes, that is the top is among the differential is viral, SLE, and systemic vascular disorder. So retinal vasculitis presenting with abundance of cotton wool spots, we should think of SLE, syphilis, and systemic vascular disorders among the top of the list. So here you see retinal vasculitis with hemorrhages, and in the periphery you see some retinal infiltrates. So retinal infiltrates are characteristics of Behçet disease, and here we see the classical pericapillary leakage or the fern pattern on FFA. So these local signs help us in narrowing down the differential diagnosis. Here, if you see, there is vasculitis, but in the periphery, the huge circumferential area of retinitis is also present. So these cases, so vasculitis with circumferential retinitis, we should think upon the line of retinal necrosis because of ARN or because of herpes simplex or varicella zoster. A similar case of vasculitis with a circumferential patch of retinitis in the periphery. So these cases are of viral in origin. So, and this is the most dramatic picture if you see the appearance of frost upon the branches. So something similar you can see in fundus also, where there is exuberant inflammation along the vessel walls. This is what is known as frosted branch angiitis. And when we see, then the list, we should think of lymphoma, leukemia, Crohn's disease, and toxo up in the order. And whenever we see a case, something like aneurysmal dilatation of arterioles at some frequent intervals, then this is the characteristic of IRWAN, that is idiopathic retinal vasculitis, aneurysm, and neuroretinitis. So that's why, along with vasculitis, attention to these subtle signs should be kept because they help us in narrowing down the list of differential diagnosis. So when we see a case of vasculitis, we should try to stage the disease. Asif sir, can you mute yourself, sir? So the various stages are stages of inflammation, which is characterized by perivascular sheathing, cuffing of the blood vessels, along with hemorrhages and central cystoid macular edema. So this stage of inflammation should be treated according to the etiology, either with antimicrobials or steroids. If left untreated, it goes into stage of ischemia, where you can see a sclerosed vessel along with development of collaterals. So these sclerosed vessels in the periphery is a sign of ischemia, and it leads to capillary non-perfusion. So these patients should be meticulously followed up for the development of neovascularization, which is the third stage of vasculitis, where you see a patient of neovascularization. And these patients have to be taken up for lasers promptly, because if not treated on time, then they'll land up in the final stage of complications, which is characterized by either vitreous hemorrhage or tractional retinal detachment. So there are certain ancillary tests which needs to be done, like FFA and OCT.
So 1 minute left.
FFA beautifully depicts the peripheral capillary non-perfusion. It also tells the area of leakage, whether it is in the periphery. You can see here the majority of leakage is in the periphery, or whether it is in the posterior pole, the leaking vessels. And also it clearly delineates the further complications of neovascularization, where you can see the excessive leakage of the neovessels. Lab tests help us to corroborate the evidence. The most important is to rule out the infectious from the non-infectious, and we should, at least some basic tests needs to be done to know the level of inflammation, like a complete blood count, Mantoux, BDRL, supported by chest X-ray or CT chest, serology to rule out the viral causes, and to rule out the systemic causes of vasculitis or connective tissue disorders, the biomarkers ANCA, ANA, RA, HLA typing to rule out Behçet and birdshot. And if all fails, then finally we have to go for vitreous biopsy or retinal biopsy. Management is dependent upon the underlying etiology. Again, as a thumb rule, infectious etiology must be ruled out because the treatment is totally different. Control of inflammation is of paramount importance to prevent the disease from going into the last stage of hemorrhage or tractional retinal detachment. So antimicrobial agent, particular to that causative agent like TB or toxo, with or without steroids. Steroids can be, if it is a immunologic cause, then we can give periocular or intraocular steroids. Systemic steroids can be started. And if the patient is on long-term systemic steroids of 10 milligram, then he must be shifted to immunosuppressive steroid sparing agents like methotrexate, azathioprine, cyclosporine. And if at the end, if everything fails, then we can use also biologic agents like adalimumab. This is my, okay, thank you.
Thank you, Abhishek. Asif, you're there?
Thank you. Thank you, Dr. Abhishek Gupta, for your nice presentation and comprehensive talk. Now, I would like to request our chairpersons and panelists to make comment and give their valuable opinion.
Dr. Arvind Jaiswal, sir.
Just one thing in the management which paucity of time Abhishek has not told. What I do in the retinal vasculitis in the management part of the things, if there is a macular involvement, then I give anti-VEGF, and after that I do FFA. If there is a lots of CNP area, then I do scatter PRP, because our place or our in country, the economic conditions is not good. They don't go for prolonged administration of anti-VEGF. So scattered PRP has a role to reduce the recurrence and other things. Thank you.
Thank you, sir.
I think Dr.
I would like to.
Dr. Biswas wants to make some
Yeah.
comment.
Sir.
Devi, sir, please unmute yourself.
May I make some comments regarding the TB vasculitis and Eales disease? Now Eales disease is found out by several studies, including ours, from the vitreous specimen, epiretinal membranes, and as well as the enucleated globe, which
We can't hear you, sir.
and a high-resolution CT chest also showed latent tuberculosis in such cases. So it's a little debatable now that whether we should still keep the name of Eales disease or not. Second point I want to make a point is that you should not miss SLE. SLE is a very important diagnosis. And here the arterial involvement is more common, and they go to the gross ischemia and neovascularization and leading to the bleeding. And that can be really serious. Another thing is that, you know, the sarcoidosis, the candle wax dripping, we read in the textbook. Actually, it is seen in only 4% cases. So you need to suspect sarcoidosis in all active all vasculitis cases, in spite of in presence or absence of candle wax dripping or skip lesions of the lesions. And the prostate branch angioitis is one of the common things we should rule out is the cytomegalovirus retinitis, and ELISA for HIV should be done. It's a sign only and can occur in various diseases like tuberculosis also. SWEPS or SOCTA is a very good investigational tool has come, which can determine the amount of ischemia much better, and the capillary vascular network is much more elegantly can be seen, but it doesn't show leakage or neovascularizations, leaking neovascularizations. These are the few points that I want. And bar shot we don't see in India. So there's a vasculitis, A29 testing is not required in our case. That's all.
I think Asif has some connection issue.
No. Am I audible, sir?
Yes, now you are.
Thank you, sir. Thank you for your expert comment. Now I would like to request Dr. KL Agarwal to introduce our next speaker, Dr. Amitabh Kumar. Dr. KL Agarwal.
Thank you, Asif boss. Dr. Amitabh Kumar is a very dynamic ophthalmologist. He has done MBBS from the Patna. Then later he finished his post-graduation from Institute of Ophthalmology, Joseph I Hospital in Chirapalli, Tamil Nadu. Then he finished fellowship in Uveitis and intraocular inflammation from Sankar Netralaya, Chennai. And presently he is the Deputy Medical Director and Senior Consultant, Uveitis and Cataract Services, Sankar Netralaya, Kolkata, West Bengal. Thank you.
Dr. Amitabh.
Thank you, Dr. Agarwal. Good evening. At the very outset, I would like to thank BOS and the Uveitis Society of India and Dr. Satyajit and his team for giving me this invite. I will be speaking on Vogt-Koyanagi-Harada disease, and we know by definition it's a bilateral granulomatous panuveitis, which can be asymmetrical. And this is one of my patients who had a panuveitis and exudative retinal detachment in both the eyes, in the right and the left eye. We went ahead with an FFA, and FA showed a typical pinpoint leak in the early stages with late cooling in the right eye, and a similar picture in the left eye. We did a swept source OCT, and it showed multiple pockets of subretinal fluid, subretinal septate. So we started the patient on topical steroids and cycloplegics and subjected the patient to 3 doses of IVMP, oral steroids, and azathioprine. And this was his OCT pre and post treatment, where you see that most of the subretinal fluid has resolved. This was a very recalcitrant case, and she had multiple recurrences. And this is one of the recurrences where she had again subretinal fluid at the posterior pole in the right eye and in the left eye. And in view of these recurrences, we put the patient on triple agent immunosuppression in the form of oral steroids, tablet azathioprine, and we topped it up with capsule cyclosporin 150 milligram twice a day. And this is at the end of 1 year when she had quiet eyes with a 612 N8 vision in the right eye and 624 N18 in the left eye. So VKH, basically, there are two clinical findings which are highly specific to VKH, are exudative retinal detachment in the acute phase and a sunset glow fundus in the chronic phase. Since it is a very recurrent disease, the posterior segment relapses are also pretty common, and they have exudative retinal detachments which are mainly limited to the submacular area. At a study done at Sankar Netralaya, Chennai, we found that in our part of the world, we have mainly probable VKH, where the multisystem involvement was only up to the tune of around 37%. And most of these patients, they responded to immunosuppressives and steroids. Whereas in China, the extraocular signs or symptoms were as high as 85.1%. VKH has got an HLA association as well, and we know that HLA-DQ1 is protective, and HLA-DQ4 carriers have a higher risk of VKH. And they also have raised intraocular levels of inflammatory markers like interleukin 6, 8, and interferon gamma. The diagnostic modalities available for VKH are fluorescein angiography, indocyanine green angiography, ultrasonography, OCT, UBM showing ciliary body edema, and of late OCT with EDI and OCTA. We know fluorescein angiography has a typical pinpoint leak with late pooling and also disc staining, whereas indocyanine green angiography in the acute state will show choroidal perfusion delays. There'll be hyperfluorescent stromal vessels, the hypofluorescent dark dots, disc hyperfluorescence. You can have choroidal folds and a diffuse late choroidal hyperfluorescence, which is the starry sky pattern. ICGA may reveal activity despite no clinical or fluorescent angiographic findings. So ICGA is of great help in these patients. The ICGA, even in a recurrent anterior uveitis attack, because most of the recurrences in VKH might be in the anterior segment, but all these eyes need to be imaged because there could be posterior segment involvement as well. And ICG can pick up these HDDs, the hypofluorescent dark dot, which we see on in figure A. This was in a recurrent anterior uveitis attack of VKH. So ICGA not only helps us in the diagnosis and follow-up of patients with VKH, but can also differentiate between the choroidal scars and active lesions. And we see here, these are the macular HDDs before treatment, and these macular HDDs have resolved after treatment, whereas the peripheral ones have stayed, so they are the scars. A non-invasive investigative tool is an OCT, which shows hyperreflective dots, subretinal membranous structures, retinal detachment, and RPE folds. And of late, with the EDI OCT available, we are able to see the inner structures of the eye as well, and this shows a thickening of the choroid and a clear demarcation between the choroid and the sclera in the acute phases, which resolves as we treat the disease. OCT can also differentiate between an acute CSCR and an acute VKH. So in acute CSCR, you may have PEDs and RPE bulge, whereas in acute VKH, you will have fluctuations of ILM, the subretinal septate, and RPE folds. And we see that in a recurrent anterior uveitis attack of VKH, the choroidal vascularity index decreases and the choroidal thickness increases. This again can be picked up on EDI OCT. In a convalescent stage, there is choroidal atrophy and loss of choriocapillaris, which can also be picked up with EDI OCT. The upper photograph shows the normal choroidal vasculature, whereas the lower one shows the loss of choriocapillaris in the convalescent state of VKH. Of late, OCTA has been a good tool. It's a non-invasive tool, and it has picked up massive impairment of perfusion in the sacculars layer in the choroid. The other choroidal biomarkers are, if we do an OCTA, the on-pass OCT at the level of choriocapillaries will show these black areas, which are flow void areas and which correspond to the HDDs and ICGA, and there's not much of loss of signal. OCTA can also differentiate between acute VKH and CSCR. Acute VKH will have these distinct dark areas corresponding to the HDDs and ICGA without a loss of signal, whereas in acute CSCR, you may have these dark areas corresponding to the PEDs with a loss of signal on structural on-pass OCT, or it may have a mottled appearance like this. As far as the treatment is concerned, the dictum for VKH is to hit it early and hit it hard, and that is with early and sustained treatment with steroids and immunosuppressive therapy. High doses of IV pulse corticosteroids are beneficial, whereas some other reports say that the route of administration of corticosteroids does not really impact the prognosis of VKH. Addition of immunosuppressive therapy as a first line, along with steroids, have a superior visual outcome as compared to steroids used as a monotherapy or with delayed addition of IMT. Now, among the immunomodulators, between azathioprine and cyclosporine, cyclosporine has got a better glucocorticoid sparing effect. Mycophenolate mofetil has also been used as a first-line therapy along with systemic corticosteroids. The most important thing is this treatment has to be continued for a prolonged period of time for at least around 6 months for treatment of acute VKH. The other local therapies available are intravitreal triamcinolone and intravitreal dexamethasone, but fluocinolone acetonide has not fared very well with VKH patients. Recalcitrant cases can be treated with rituximab.
1 minute.
Anti-TNF alpha in anti-TNF alpha, adalimumab does much better than infliximab. So the take-home message is, in our part of the world, it's mainly a probable VKH. It needs a prompt investigation, early diagnosis, and initiation of appropriate therapy for an appropriate period of time, because this is a recurrent disease and these patients need a long-term follow-up. Thank you for your patience.
Thank you. Thank you, Amitabh. Thank you, Dr. Amitabh, for your excellent and comprehensive talk on VKH.
Thank you.
Now I would like to request our chairpersons, Dr. Arvind Jaiswal sir and Dr. Milind sir, to comment and.
Frankly speaking, in district, I never diagnosed a case of VKH, so I can't comment very properly here. Let the senior faculty person to answer.
Dr. Arvind Jaiswal sir, your opinion, please.
I have seen few cases of VKH in my practice of about 25 to 30 years. One thing is exudative detachment, and what Dr. Amitabh has said, I endorse that. Nothing to add more in that.
Can we request Biswas sir also to please?
Thank you, sir.
One of the very important point in a VKH, you should not miss the multiple look CSR. So an fundus fluorescent angiogram and SSOCT will help us to find out that it's not a CSR, it's a VKH only, and that's quite important. And VKH is one of the diseases where you do not need any laboratory test. You need only ancillary investigations like FFA, ultrasound, and SSOCT. And SSOCT is also helpful in monitoring the treatment. Particularly if the patient's retina is attached, still there could be a choroidal thickening more than 330 micron, and then you can keep the patients on treatment like steroids and immunosuppressive agents. The hitting hard and hitting hardly is very important in VKH. If you don't hit early or hit hard, you would be really leading to a chronic stage, which lead to a lot of complications like subretinal fibrosis, choroidal neovascular membrane formations, glaucoma, and recurrent anterior uveitis. Another important thing is that the VKH can present with the unilaterally initially and then become bilateral, or present with the disc edema or hyperemia of the optic disc, and sometimes they get headaches also. And they go to the neurologist, and neurologists think that it is a neurologic disease, and then they try to treat with the standard treatment. These patients often miss the lost time and going to the neurologist over there, the headache problem, neurology, meningeal irritations kind of problem. So these are the few things I want to tell you, and the duration of the treatment is long. It's at least 6 months to 9 months.
Can I just make one point here?
Please.
Yeah, first of all, thanks Dr. Amitabh and thanks Dr. Biswas sir for those great points. Just one more differential which we should also keep in mind is malignant hypertension. Sometimes hypertensive retinopathy can also present with a choroidopathy sort of a picture where you may see multiple neurosensory detachments. But the point to note over there is again the subtle clues which you can get in a good clinical evaluation, where you may see those vessel tortuosities and those signs of hypertensive retinopathy. And it's important to check BP in these cases because that will help you in arriving at a diagnosis of probably just a hypertensive choroidopathy and not a VKH. So that is another one differential which should be kept in mind. But otherwise, VKH in most cases is a clinical diagnosis, and the help of associated investigations like an FFA or an OCT can in most of the cases help us in arriving at a diagnosis and starting our treatment early in these cases.
That's a very, very good comment, Mudit. I had a young lady who used to come with bilateral exudative retinal detachment, and after 2 days of IVMP, she would become okay. And whenever we did the FFA, we found choroidal ischemia, those round areas of hypofluorescence. One day after 4 years, she came and told me, I am okay. And I said, what happened? She said, I was diagnosed with a pheochromocytoma. It was operated. And since then, my exudative retinal detachment is gone. So for 3 years, we kept on getting a slowly depigmented fundus because of the recurrent retinal detachment, and because pheochromocytoma is episodic. Therefore, you were getting recurrent attacks of bilateral exudative retinal detachment, and it's been an eye opener for me. And now I always get the blood pressure checked. Sometimes the blood pressure will come normal when the exudative retinal detachment is there, because the episode of pheochromocytoma is already gone. That crisis is gone. So, even BP monitoring does not clinch the diagnosis.
What should be the treatment protocol in cases of recurrent BKH cases?
Are you asking me, Dr.
Yes, Amitabh, you are the expert.
No, I think the most important thing with VKH is, as Sir also said, is to start early treatment, and the treatment is prolonged. And now with the latest investigative tools available, which are non-invasive, probably if I have to follow up a case of VKH, I would probably just do an OCT with EDI with enhanced depth imaging, and then base my treatment depending upon the choroidal thickness and the other signs of OCT with EDI. And I think the most important thing is these patients, this is one of the diseases which will need early initiation of high-dose corticosteroids and immunosuppressive therapy. And at times they might need triple agent immunosuppression because there could be multiple recurrences, as in one of my cases. But in a series of around 300 cases, which I have seen in my experience till now, I think if it is treated early and if it is treated appropriately, the end result may not be all that bad. I think it's one of the better uveitis to get.
It's not always that good. That VKH is that if it comes to the recurrent, that can cause a lot of problem. And here that triple immunosuppressive therapy can be given. And if the last result will be going to that cyclopentolate, and that's the strongest immunosuppressive agents. And I have seen few cases which didn't respond to other immunosuppressive agents, and I went higher up, and cyclopentolate caused reduction of the inflammation. Biologics is no good for VKH.
Yes, sir. But is this question always questionable, sir? How long we can go for?
At least 6 months.
Dr. Manisha, your comments?
So I think all the relevant points have been already mentioned, and what is important in VKH, like Dr. JB also mentioned, that we have to hit it very hard in the early stage, and you have to avoid the chronicity and the chronic stage of VKH to happen. So for the patients who are, if they're coming with the first episode, probably we will be at least continuing the immunosuppressants for something like 6 months. But I do not even hesitate if they're having recurrent episodes to go on for a year or 2 years also to keep them on immunosuppressants. Because getting recurrent attacks and then making them go into a chronic stage is more harmful for the vision rather than avoiding a recurrent attack. So that would be my take on it.
Agreed.
Glaucoma is an important complication of VKH. Is that a lot of times you should check that IOP and then take the help of your glaucoma colleague.
I'm very happy, sir, you mentioned that, and that is something we all need to be aware that sometimes the first presentation of VKH can be an angle closure glaucoma. And in a routine angle closure glaucoma, you have to use pilocarpine, but here in VKH, you have to actually use atropine or a dilator. And the mechanism, of course, is because there's an inflammation and there's a forward movement of the
ciliary body rotation,
body, and that's causing an angle closure. But it's very important. I'm so happy sir mentioned it, because very often the general ophthalmologist or any one of us, we tend to miss diagnosing a VKH when patients present with a high IOP.
And also, ma'am, we can do the gonioscopy to know the neovascularization of the angle can early.
Okay, thank you. Dr. Asif, can we request you to?
Thank you. Thank you, JB sir, and Dr. Mudit, Dr. Shishir, and Dr. Manisha to enlighten us about VKH. Now, I would like to request Dr. next speaker, Mudit Tyagi. Shivani.
Good evening, everyone. It's my pleasure to introduce Dr. Mudit Tyagi. He has completed his residency training from BJMC Ahmedabad and in 2010, and further completed his VR fellowship from LVPI Hyderabad. And he continues to be a consultant over there at LVPI Hyderabad. His areas of interest include uveitic specialties like VKH, ocular syphilis, and ocular inflammation. And he is and also has interest in ocular inflammation, complex vitreoretinal surgeries, endoscopic retinal surgeries, and especially the vitreoretinal surgeries in uveitic disorders. He is also interested in imaging in uveitis and posterior uveitis. He has to his credit achievement and honors awards in American Society of Retina Specialists and awards for surgical videos in URetina and ASRS. He also has won the award for Best Innovation of the Year in the VRSI in 2019 for his work on fibrin glues in retinal detachment. Over to Mudit sir for his presentation.
So thank you so much for that kind introduction. And may I just share my screen, please? Yeah. So are my slides visible and am I audible?
Yes.
Yes, sir.
All right. So first of all, let me thank the Bihar Ophthalmic Society and USI for giving me the chance to talk about these two diseases. And like most infective retinitis and diseases which affect the retina, a lot of times there's a pattern recognition, which is an underlying thing in these infective cases. We can identify a lot of them by the characteristic pattern which they have. So I'll be talking about two common diseases, with two common viral diseases which can affect the retina. First is the CMV retinitis, and second, I'll be talking about acute retinal necrosis. Now, CMV retinitis is one of the most common opportunistic infections affecting the eye, and your patient may present in any sort of a way. They may be asymptomatic initially. They may come with complaints of floaters, scotomas, or loss of vision. And usually there's an increased risk of development of CMV retinitis in patients with a decreased CD4 count or count of less than 50 cells per microliter. Now, if you look at the clinical presentation of how CMV retinitis might look like, you will see these areas of retinitis, associated some areas of central clearing, surrounding hemorrhages, vasculitis, arteriolar sheathing, and again areas of retinitis with hemorrhages. And these can be a clue to an underlying CMV retinitis. Usually you will see a minimal anterior chamber reaction. These lesions start in periphery and move progressively centrifugally. They may be wedge-shaped lesions. You may see associated vitritis. I am sorry for that noise in the background. And associated hemorrhages in these eyes. Now, a lot of times CD4 counts can be a predictor to the type of disease which we are dealing with. And they can also help us in associating which of the disease is manifesting. So if CD4 counts in a patient are less than 500, usually in HIV patients, we see Kaposi sarcomas, diseases like lymphoma and tuberculosis. When the counts fall to as low as 250, then you start seeing manifestations of pneumocystosis and toxoplasma. And counts less than 100 are usually associated with CMV retinitis, varicella zoster virus retinitis, disease by Mycobacterium avium complex, cryptococci, and other. Now, the main classical forms of CMV retinitis are the classical form, or which has been described as pizza pie appearance, where you see this extensive retinitis along with surrounding hemorrhages. An indolent form and the frosted branch angiitis, something which Dr. Biswas had already mentioned in one of his discussions. And we'll see some of these images of frosted branch angiitis in the next few slides. So you may have a pizza pie appearance where you see this extensive retinitis with these flame-shaped hemorrhages. You can again then see this frosted branch angiitis where you see this perivascular involvement around the blood vessels. So in the fulminant form, the point to remember is that many times there's an absence or very minimal vitritis. And the reason for that is that you are dealing with an immunocompromised patient who does not have the capacity to host an immune reaction. And that's why you see a reduction or a minimal vitritis in these cases. So these is the images of a fulminant form of CMV retinitis. And one of the most common causes of a decreased vision in these cases is a macular involvement. Compared to that in a granular or the indolent form where you see this retinitis areas with some central clearing and this granularity, the reason for loss of vision in subsequent times can be a retinal detachment which occurs in these, because these heal with necrosis and you can get a detachment which occurs from those necrotic areas. There is also a perivascular form, or what we call a frosted branch angiitis. And like I said, Dr. Biswas had already mentioned, one of the causes for a frosted branch angiitis is CMV retinitis. But apart from that, we must remember that it can also be idiopathic. frosted branch meningitis may be a manifestation of Behçet's disease, sarcoidosis, lymphomas, leukemias, and SLE. And lastly, there can be a mixed form, which is one of the rarest, where you can see associated indolent as well as the fulminant forms of retinitis manifesting together. So again, a pattern of CMV retinitis where you see these retinitis lesions along with hemorrhages. But the point to remember is that not only is CMV retinitis a disease of HIV positive patients, it can also occur in patients who are otherwise immunocompromised. And this includes patients who are on long-term immunosuppression for either a rheumatological disorder or an underlying blood dyscrasia, or even patients who are undergoing chemotherapy for any of the cancers. So patients on chemotherapy, patients of blood dyscrasia like non-Hodgkin's lymphomas and leukemias, and patients on long-term immunosuppression may also present with this, and we should be vigilant about examining the retinas of these patients. So these are the diseases which can occur in otherwise non-HIV but immunocompromised patients. And this is an image of one of our patients. He is actually a pediatrician on long-term immunosuppression for vaginous granulomatosis with rituximab and mycophenolate mofetil. And he presented with this retinitis lesion at the posterior pole and in periphery. And if you look at the lesion, you see these retinitis areas along with some areas of hemorrhages. He was diagnosed as CMV retinitis, and when we took a PCR, the PCR from the vitreous tap came positive for CMV, and he was treated accordingly. Moving on to the second disease called acute retinal necrosis. Now, this was a peripheral necrotizing retinitis with retinal arthritis, which was first described in 1971. And subsequently, Young and Bird introduced the term ARN or acute retinal necrosis for this disease. Now, if you look at the diagnostic criteria which have been defined are one or more foci of retinal necrosis with discrete borders in the peripheral retina, rapid circumferential progression of the necrosis in absence of antiviral treatment, evidence of occlusive vasculitis with predominant arteriolar involvement, and prominent inflammation in the vitreous and anterior chambers. So this is how an acute retinal necrosis lesion will look like, where you will see these areas of retinitis which may be confluent in the periphery. They can occur in immunocompetent patients. You may have moderate anterior segment reaction. Like I said, they are located in the peripheral retina. They have a circumferential spread. They rapidly progress if an appropriate treatment is not started. They may be associated with the prominent vitritis and have an occlusive retinal arthritis. Now, the point to remember is that three most common differentials for a patient who presents with a prominent vitritis are: number one, acute retinal necrosis; number two, toxoplasmosis; and number three, either an endogenous endophthalmitis or occasionally a pars planitis. But whenever we see a patient with prominent vitritis, a good indirect ophthalmoscopy should be done. And if we see areas of retinitis in the periphery, we can be assured that we are probably dealing with an ARN. So this is how an ARN lesion will look like, where you will see these multiple confluent areas of retinitis with arterial involvement in the periphery. Another patient of ARN who was treated with systemic antivirals, and subsequently you can see that the lesions start regressing, but it also leaves behind sclerosed vessels and optic atrophy. And the most common cause of decreased vision in patients of ARN in the initial months is optic atrophy. But in the later months, the most common cause of decreased vision becomes retinal detachments, which occur because of breaks which occur in these areas of peripheral necrosis. So Dr. Shishir had mentioned a case of toxoplasmosis, and that's why I just added this slide. So this was a patient who had this peripheral demarcated retinitis lesion, but the clue over here to the fact that this was not viral but something else is the fact that if you look carefully, you will see this area of pigmented patch or a scar adjacent to it. And that is where a good clinical evaluation can help us in arriving at a diagnosis, even in confounding cases. So this was a patient who had a peripheral retinitis, but we were fortunate to notice the fact that this also had a scarred lesion. And then we diagnosed this patient as having an acute lesion because of the underlying toxoplasmosis. This patient was treated with clindamycin and Bactrim DS, and this is how the lesion responded. So the point is that ARN is also a morphological diagnosis. It basically describes a clinical picture, which can be because of underlying different microorganisms. So varicella zoster virus accounts for majority of cases of ARN, but otherwise the other two viruses which are important and implicated are... All right, so I'll just skip in a minute. Just give me 1 minute. And this is progressive outer retinal necrosis. It happens in immunocompromised patients, has minimal AC and vitreous inflammation. I'll just briefly mention that sometimes AC tap and wet biopsies can be helpful in diagnosing. Treatments are with the help of conventional antivirals like ganciclovir, valganciclovir, which can be both intravitreal and intravenous. And I guess all of us are aware of the treatment. But just one last word of caution: valganciclovir should be used with caution in patients who have got a pre-existing cytopenia, and these patients' blood count should be monitored because it can lead to a significant life-threatening myelosuppression. And with that, I'll just conclude my presentation. And the point I would like to emphasize is that pattern recognition plays an important role in most of these infective retinitis. Thank you.
Thank you, Dr. Mudit Tyagi, for your beautiful presentation on CMV retinitis. Now, I request our chairpersons to give their opinion. And
Udit, excellent talk, and your photo that you added after my comment is very similar to the case I have shown. It is only yours was in the nasal quadrant, mine is in the temporal quadrant. They look identical, and the angiography was very typical in my case. So you did not need to do it, I'm sure, but fantastic case. The other thing is, sometimes in patients who are diabetic, even diabetes is considered partial immunosuppression.
Yeah.
And if you give Ozurdex implant, there are quite a few reports of CMV retinitis. I have seen one patient in a doctor here in my practice who developed CMV retinitis after Ozurdex implant.
Exactly. And the other point is, whenever we give steroids in any infective retinitis without the cover of an appropriate antimicrobial, we have seen these patients coming with a very confounding picture. And those are the ones who have either been given IVTA or Ozurdex, and the toxoplasma will then assume a larger lesion. It will spread to the periphery. So HIV positive patients and patients who have been given a steroid without an appropriate antimicrobial cover behave as confounders.
Even with appropriate antimicrobial cover, sometimes it will go out of control.
Yeah.
Dr. Tyagi, you mentioned the PCR test. What is the actual site and what amount of the vitreous take for the PCR test?
So it's ideally preferable to do it in the visualization, and if you can go close to the lesion and just take some of the cells, even a 0.5 ml of vitreous is more than sufficient to arrive at a good diagnostic yield. Of course, you have to be in talk with your microbiologist and inform that you are sending that sample. But even a very minimal 0.1 to 0.2 ml of sample also sometimes is sufficient for us to arrive at a PCR diagnosis. But usually I end up resorting to PCRs only in cases which are not responding to treatment or where I am facing a diagnostic dilemma. Many a times these are diagnoses which can be clinical and they do respond to your antiviral treatments also. So I don't end up doing a PCR for every one of my patients. Dr. Manisha
simply we can spray it with the needles, or we can
Biswas wants to make some comments. Let's have Dr. Biswas first.
Yeah.
So, there's a ARN case. The PCR is important. The reason is that it can be caused by the CMV. It can also be caused by the herpes virus. If it is a CMV, you need to put the patient on ganciclovir, oral or intravitreal injection of ganciclovir. Another very important point is that if you see a CMV retinitis, you should rule out the any immunosuppression. CMV retinitis doesn't occur in immunocompetent patients in any form. So you should rule out for that CD4 count and HIV and see that whether the patient has got transplant or getting immunosuppressive for a long time. Renal transplant and other transplant patients has come down with the CMV retinitis much more less. The reason is that they have switched to mycophenolate mofetil in many of the cases, and that got less immunosuppression. And another important thing is that I wanted to tell you that is CMV retinitis, if you have seen once, it's such a classic picture, or ARN, if you have seen once, you won't miss it. Except for the toxoplasma, it may confuse the ARN. Otherwise, CMV retinitis and ARN are very classic. ARN is the periphery, CMV retinitis will be in any part of the eye, and they've got a dry granular appearance and with hemorrhages inside the necrotic retina.
Mudit, I wanted to say one thing.
Thank you, sir.
Can I say something?
Yes, sir. Sure.
You see, Mudit, the incidence of retinal detachment is so high in acute retinal necrosis. Now I have started advocating early vitrectomy when the retina is still attached in patients of acute retinal necrosis, and then debulking the antigen and then going ahead and doing a barrage. And that probably might have a better visual outcome in the long run. What is your opinion? Because you are an extensive vitreoretinal surgeon yourself.
So early vitrectomy does help, but I do not see the role of prophylactic barrage laser. The reason for that is, first of all, the fact that initially in the initial presentations of ARN, you will see a dense vitritis, and that will preclude or hamper your ability to do a good barrage laser. That's the first thing. The second point is that even if you do a barrage laser, sometimes this retinitis does progress, and if it progresses and approaches the area where you have done a barrage, then you'll end up getting necrotic holes in that area where you have done a barrage laser. We actually went back and analyzed our cohort of ARN patients, and out of 130 patients who we analyzed, we found that prophylactic barrage actually does not offer any prevention or protection against a detachment. But the jury is still out in the sense there are some people who advocate. I do not. But I do totally agree with you, sir, over the role of a prophylactic early vitrectomy. It helps in debulking. It also helps in relieving the vitreous traction, which can occur over these peripheral retinal or retinitis lesions. And once you remove that, that also reduces the chances of a subsequent detachment, which can occur in these cases.
Absolutely.
When you do the vitrectomy, you should put the silicone oil in such cases.
Heavy silicone oil.
Yeah.
Heavy silicone.
So
Yeah, Manisha.
are you advocating an early vitrectomy even in the absence of a retinal detachment?
Exactly.
So, like, to be honest, our experience of early vitrectomy at this point of time is very limited. We have done it in very few patients. So I would not right now advocate it. I do believe it has got a role in preventing future detachments, but it is something which maybe we will be able to have a better answer in the next few years. Right now, there are papers which have shown a role of early vitrectomy, but we are not doing it routinely, to be honest. Right now, we are still treating our patients in the way we were treating them earlier with antivirals and steroids. There are now multiple publications which are coming up, including one which has come from Dr. Vishali's group also, which has shown the role of early vitrectomy in these lesions. But we still need more evidence to come at that diagnosis where we can probably include it as a practice pattern in our ARN patients.
It will depend on the amount of retinal involvement.
Also.
If the involvement is coming under control, then you can see reasonably that the inflammation is going down. You may not do it. But if you are seeing active inflammation and patient has come late, when you do the vitrectomy before the retinal detachment, then the final outcome will be better. Otherwise, these eyes go into phthisis if they get a retinal detachment.
The point I want to make.
Yeah, sure, sir.
Another point is that I want to make is that if it's a unilateral acute retinal necrosis, once you treat it, you do vitrectomy also, you should put prophylactically oral valsaclovir tablet, because these patients tends to develop that retinal necrosis in other eye also. So the recurrence and as well as the preventing the involvement of other eye is good idea to give at least 90 days or more of oral valsaclovir in such cases, 1 gram 3 times daily.
Yeah. So if I can just add to that, usually end up giving our patients oral antivirals, either Velacivir, for at least 6 to 8 weeks. The reason is that most of the recurrences, plus also the involvement of the fellow eye, has been known to occur within this duration. So as a rule for all of our ARN patients, we do end up giving them antivirals for at least 6 to 8 weeks.
So I would just like to clarify one thing over here, and I don't want a wrong message to go out. We are advocating a surgical intervention for all these cases. And I think there is a lot more to learn about the role of an early vitrectomy when you don't have a retinal detachment in these cases. You would actually be treating majority of these cases medically with intravitreal drugs and with oral antivirals. And it will be only the last resort in two conditions. Either you are doing an optical vitrectomy where you have very condensed vitreous, or you want to clear up the vitreous where you want to do a prophylactic laser. And as Dr. Modit and Dr. Shishir mentioned, that there are a few reports coming of an early vitrectomy possible role in controlling the inflammation. But I think that would be the last resort, because we can't forget that these are inflamed eyes. And we have to
Exactly.
be very careful in these eyes while we are doing a surgical intervention.
Yeah. And the primary management is at this point of time definitely medical. And like what Dr. Manisha said, that's not a message which we want for the audience. For us, the primary management is systemic antivirals and appropriate medical treatment.
Yeah, and the
Next,
downside,
but
and the
I do
downside also
counsel.
would be development of breaks during surgery. So you have to weigh and weigh the risks and benefit of any surgical intervention. Absolutely.
But I do counsel my patients that you have got a high chance of development of retinal detachment, particularly after the resolution. And they said that won't come about 3 months after or 6 months after. These patients, even after getting better, you need to see them early and warn them about retinal detachment, because the necrotic retina, they tend to develop breaks and develop retinal detachment. Particularly, there's a little traction over there. They tend to develop large retinal break leading to the retinal detachment. And if it is delayed, there is a significant amount of vision loss occurs.
And I'm sure Modit is going to agree with me that these are one of not the so easy eyes to induce a posterior vitreous detachment. And they are extremely stuck to the retina. And that's the time when you can actually induce a lot of breaks in this inflamed retina. So one needs
Exactly.
to
Absolutely.
be careful.
Very difficult
And-
detachment surgeries and very different from the conventional RDs which we do otherwise. Yeah.
Absolutely.
ARN is a real emergency in Uveitis clinic. And there is only few emergencies in the UVA clinic is there. That's one is the ARN. The same day you should admit the patient and give interventions as cyclovir or intravitreal ganciclovir on the same day. Is like an endophthalmitis you are treating. That kind of urgency should be there.
Okay, we have had a good long scientific discussion, and I'd like to express my deep gratitude to everybody, especially Sir Jyotirmay Biswas sir, who was there with us throughout the evening. Our deepest thanks to you, sir, from the bottom of our heart for guiding us. We'd like to thank Dr. Vishali ma'am, who was with us during the webinar. I would like to profusely thank Dr. Manisha Agarwal, who helped us build this program in formulating the whole program and bring this all together. I'd like to thank Dr. Amit Khosla, who is with us. I would like to thank Dr. Pratim Majumdar, Dr. Vibhuti P. Sinha, who is so supportive, our secretary. This is the new team of Bihar Ophthalmic Society with Dr. Milind sir guiding us, and Dr. Vibhuti P. Sinha. He's our new dynamic secretary. I would like to thank Dr. Shishir Narayan, who made a wonderful presentation. I would like to thank Milind sir himself for guiding and blessing us and supporting, being so supportive with all this program. I would like to thank Dr. Arvind Jaiswal sir, who has, though he keeps saying that I have retired, but he is always active, he is always supportive of all our programs, always blessing and encouraging us. He's such a big pillar of support to us. Dr. Vishwaratan sir and Dr. Sanjay Sharma sir, a big thanks to you for being on the panel. A big thanks to Dr. Abhishek Gupta and Dr. Amitabh Kumar and Mudit Tyagi for the wonderful presentations you have made and for the time that you made out for this webinar. I would like to thank our member scientific committees who are all very active over here, Dr. Gyan Bhaskar, Dr. Asif Shahnawaz, Dr. Dinesh, Dr. R.K. Rai, Dr. K.L. Agarwal, and Dr. Shivani for all the moderations that they were doing in between. A big thank you to everybody. And I would like to thank Sunil ji, Radiotech, and our sponsor for this program, who did all the sponsorship, Aztec company. I'm sorry about that. I'm very grateful to them. Big thanks to everybody. This will also be available on YouTube, so it can be seen later also. Big thanks to everybody, and good night to everybody. Thank you so much.
Thank you so much. Thank
Thank
you.
you. Thank you very much
Thank you.
Yeah.
for a
Thank you
wonderful
so much.
evening
Thank
and a
you for a
wonderful
great evening.
webinar.
Yeah.
And hospitality from Patna, which is so typical. We could feel that. Wonderful.
Thank you so much, sir. People physically during our manual.
So someday we will come physically.
Sure.
Taken vaccine.
Yes,
Yeah.
sir. Dr. Satyajit has promised a good trip to Patna.